Good evening, everyone. Welcome to our 2025 Fall Town Hall. If we were hosting this tomorrow night, we would have called it our Winter Town Hall. But since we're right before the snowstorm, I think it's still fall. So thanks for you guys for joining us. In terms of our agenda this evening, we're gonna first cover some CF program clinical and research updates from our program at Children's Hospital Colorado. We're then going to be joined by Kevin Wilson and Ellen Stern, who are members of our Children's Hospital Community Health and Advocacy Division. And they're going to provide some updates and sort of foreseen of the landscape with changes to Medicaid. There's many changes we don't know what will come to be, but things that they anticipate and they'll be watching out for. So they're going to be joining us here shortly. Mike and possibly others will be giving us Rocky Mountain chapter updates, and there will be plenty of time for questions and answers. And during even the course of my talk, if people have questions, feel free to chime in with the questions. So we're going to start with our program-specific registry reports. This is looking at data that we collect as part of the CF Foundation's patient registry that many of you consent to. And it's our best way to learn about how we're doing as a center, how the entire US CF community is doing in terms of key metrics. I'm going to start out with really sort of two of the biggest ones, which is a measurement of lung function, FEV1 or forced expiratory volume in 1 second. As well as BMI, which is body mass index, a measure of nutritional status. And we're looking at data from 2014 compared to the most recent data, 2024. The 2025 data we'll receive as a program sometime next spring. So we'll be collecting through the end of this year, and then there's a database lock and a database cleanup and stuff. So we'll see our 2025 data sometime next spring. But so this is data through 2024, and you can see, in 2014, our average FEV1 in our clinic population, and this is measured in people 6 to 19 years of age, was 98.6%. It's increased now to 105% across our clinic population. Our body mass index was the 50th percentile in 2014 and is now closer to the 55th percentile by last year's data. And you can see how we compare to all the other pediatric programs across the U.S. Care Center network, where our lung function is a bit above average and our body mass index is a bit lower than the average. But I really think we are where we want to be. I think having a lung function above 100% as a clinic and a body mass index somewhere close to the 50th percentile is really being healthy and where we want to be. Looking a little bit more granularly at the data, first we're going to look at lung function in children 6 to 12 years of age, where you can see how this has improved over time from about 100% predicted to, again, last year's data was close to 105% predicted, and where we are represented here in red. All the other blue vertical lines represent all the other pediatric programs across the country. So again, we're a bit above the average for younger kids' lung function. Looking at lung function in the teenagers, I think it's pretty just remarkable. Our teenagers have an average lung function of over 107% predicted. Again, putting us really in the top quartile of sites across the country in terms of our average lung function. So really pretty amazing how well our children and adolescents are doing in terms of lung function. Another core metric, as I mentioned, is looking at our weight for length in younger kids or body mass index in older children. And this is an area that, we haven't been quite as good when you look at national statistics. Our average weight for length among infants less than 24 months of age is at the 47th percentile. Now, that's actually pretty good, right? We strive for the 50th percentile, but you can see that the average across the care center network really is closer to 63rd percentile. So I don't think we're doing poorly here, but I think there's always room for improvement. And we do believe that, achieving a better weight and a better weight for length in early infancy is associated with long-term nutritional status and growth. And it's a reason why we push for it. And it's certainly an area that we're putting efforts into to improve through a formal quality improvement project. Looking at the body mass index, which again is looking at older children between 2 to 19 years of age. Here, while we are below the national average, I think we're doing well with the BMI at the 54th percentile. I don't think we want to be at the 75th or above percentile when it comes for BMI. I think being somewhere closer to the 50th is where you want to be. We've had a slow but steady improvement in this measure, but now we're just hoping to look to maintain over time at that level. Looking at microbiology or airway infections, as you know, when you come in for clinic visits, this is a standard thing where we're testing for different bacteria. In general, we were detecting fewer airway infections in our children with CF. This is looking at from 2015 to 2024. The main bacteria that we see in most of our children with CF is Staph aureus that we see in just under 75% of the children we follow. But there's really been a decline in many of the other microbes that we used to see, including Pseudomonas, including MRSA, including Haemophilus, Stenotrophomonas multifida. So that's good. I think some of this certainly relates to the use of CFTR modulator therapy, but we're seeing less of this. Now, staph is a bacteria that many of us, even without cystic fibrosis, carry in the back of our throats. We carry on our skin. So it's not as per se specific to people with cystic fibrosis, but it's still the most common bacteria we see in the airways of children with CF. And looking at how sort of the infections at our site compared to other sites, you can see that our, Pseudomonas aeruginosa culture positive rate last year was 8.8%, which was, about a third of that, or, somewhere around half to a third of that seen compared to the national population. And then our rate of MRSA infection, another both sort of opportunistic and drug-resistant pathogen, is about half of what it is across the nation. So we have fewer infections here. Part of that probably does relate to our higher altitude, our drier climate, that we see less in the way of sort of bacteria that likes water in some ways. So that may be a reason we see less of these bacteria here in Colorado. Guidelines, we request you guys come to clinic quite frequently. And so that we look at that as one of the metrics in terms of 4 visits a year, having 4 cultures and 2 lung function tests. And for us, in the last year, about 32% of our clinic population met these guidelines of 4 visits, 4 cultures, and 2 lung function tests. Now, the care model in a way is changing on modulator therapy. For people who are 6 years of age and older, doing well on a stable modulator, the recommendations now are to be seeing children 2 to 3 times a year. And so this is a metric that will decline nationally, but there's, we do think that, seeing you guys regularly in clinic where we can stay on top of changes in clinical status, measuring lung function, checking growth, testing for bacteria. We do know that more frequent visits, historically was associated with better outcomes in people with CF. So it is why, in part, there are these guidelines recommending, historically 4 visits a year and soon to be changing to 2 to 3 visits per year, and those on a stable CFTR modulator regimen. Another thing we ask for our older children and adolescents to do is annual screening for diabetes. About 25% of the US CF population has CF-related diabetes, and the guidelines call for formal testing with an oral glucose tolerance test beginning at 10 years of age. And you can see in the last year, about 58% of our older children and adolescents 10 years of age and older underwent an oral glucose tolerance test, a little bit below the national average of about 60% of it. And so this is something that we we review quarterly, and some of you, at least for those of you who have older children or adolescents, we're sending reminders through MyChart, sending letters to do the oral glucose tolerance test. I'm going to pause there and just see if anybody has questions for me about any of the data I shared thus far. If not, I'm gonna keep going. The only really sort of team member update to provide is that we actually have two new social workers that joined our team this year. One is Joanne. Joanne joined us earlier this summer and early fall. And then Brianna is actually starting with us later this month. So that's been the only area that we've had some turnover in the last year. Everybody else really is the same. I'm now going to move to sort of a research update. Some of this is I'm going to highlight data from our center, but also nationally. And I'm going to first start with a slide we're very proud of here, that that Colorado continues to rank #1 in terms of the number of participants who are enrolled into TDN studies. The TDN stands for the Therapeutics Development Network. This is our CF Clinical Trials Network, and we receive these data on an annual basis. We're the orange or yellow vertical bar, and sort of they combine both our pediatric program at Children's along with our adult program at National Jewish, and that's how they do it for many of these other programs and centers as well. And again, we're #1 in terms of these weighted units enrolled. They're weighted based in part on the complexity of the studies. I think this is a testament, both to you, our families who participate in these studies. It's a testament to our research team and really our commitment to research, and that we believe it really helps CF. It helps to advance our understanding, and it helps lead to better treatments for people with CF. So something we're very proud of here. I wanted to just spend a few minutes to talk about what we're learning from a variety of different studies that are sort of investigating the benefits of highly effective CFTR modulator therapies on lung health and other organ systems. And several of you are probably participating in the BEGIN and PROMISE studies. Some of these are studies being conducted in other countries, including the UK and Germany and France here. When I use the word highly effective CFTR modulator therapies, currently we think of 3 of them as being highly effective. One being ivacaftor monotherapy, which the trade name is Kalydeco, which is approved down to a month of age. The triple combination elexacaftor, tezacaftor, ivacaftor, which I'm going to abbreviate ETI going forward. This is also called Trikafta. This is currently approved down to 2 years of age here in the United States. And then the most recent triple combination therapy of vanzacaftor, tezacaftor, and deutivacaftor with the trade name Alyftrek. This was approved really at similar time last year, down to 6 years of age. And so, in the clinical trials of these medications, we know that they improved lung function, they improved FEV1, we know they improved growth, and we know that they reduced pulmonary exacerbations or respiratory illnesses requiring hospitalization and or antibiotic therapy. But, being that many people with CF are going to be on these meds for a long time, there's much that we need to learn about these meds and what it's doing beyond just those core measurements that were done in the clinical trials. So in this first slide, just talking about some of the benefits beyond FEV1, one measurement is something called the lung clearance index. I told you that our average our average FEV1 in our clinic population is about 105% predicted. It's actually hard to improve upon that number. But we still think that there's things going on in the lungs. And the lung clearance index is another sort of physiologic measurement that we do as part of the PROMISE study, as part of the BEGIN study. Some of you undergo this measurement that gives us another sense of how air is moving through the airways. And somebody could have a normal FEV1, but an abnormal lung clearance index. And we find that, ETI or Trikafta therapy certainly improves that measurement in younger kids and older kids. There's centers that are looking at MRI changes where they can show changes. MRI is not quite as sensitive as CT scanning, but the benefit of MRI is there's not radiation with it. And so, it's often used in research studies and sometimes clinically, but we can see different improvements on MRI scans, such as mucus plugging, sort of ventilation and perfusion abnormalities, where that's resolved after ETI therapy. So this is, we're seeing benefits both structurally in the lungs as well as physiologically. Another really important thing, as I talked about, is infection. And we're certainly seeing reductions in infections after starting ETI therapy. Here's data looking at Pseudomonas aeruginosa, one of the CF really specific bacterial pathogens we see. And this was data that was gained through the PROMISE study. So some of our older adolescents who participate in this study would cough up mucus. We would look at sort of the bacteriology, including Pseudomonas, where we can see sort of an elimination of Pseudomonas in almost a third of people who are treated with Trikafta. And in those who continued to culture Pseudomonas, there was much less. There was a 2 to 3 log reduction. So that's taking somebody from, let's say, 1 million colonies down to 100,000 colonies or 10,000 colonies of Pseudomonas per ml of mucus. So pretty significant reduction in Pseudomonas infection. Another thing that we've looked at in the PROMISE study is inflammation, both in the lungs and in the circulation. And these are data just showing reductions in 2 measurements of airway inflammation: neutrophil elastase activity and calprotectin. Both neutrophil elastase and calprotectin are things made by neutrophils. And it's really the neutrophil, which is the main type of white blood cell that infiltrates the airways of people with CF. And it's actually our own body's inflammatory response that in part mediates the airway injury and damage that takes place. So there's for years been thoughts that we needed both highly effective modulator therapy as well as anti-inflammatory treatment. And I think that's still going to be the case for some, particularly older people with CF, people who are still infected with Pseudomonas. But I don't think everybody with CF is necessarily going to need an anti-inflammatory therapy, because we really did find a pretty significant reduction in various measurements of airway inflammation, as well as in the bloodstream and circulating inflammation through the PROMISE study. And we're continuing to examine this through 4.5 years of ETI therapy. Another thing is the idea that, infection and inflammation are related, and that those who do have persistent infection are the ones who still have more residual inflammation. So this is looking at those who sort of cleared their Pseudomonas, that there was also really a dramatic decrease in this measurement of inflammation, neutrophil elastase, whereas those who did not clear their Pseudomonas still had persistent infection. While there was a decrease in inflammation, they still had detectable free elastase activity. And this is at levels that we think that can mediate injury in the airways. Another thing that we found is a decline in non-tuberculous mycobacteria infections. People with CF don't get tuberculosis or TB, but they do get infection with non-tuberculous mycobacteria, which is a cousin of TB. And Stacy Martiniano at our site and Jerry Nick at the adult site, they've been leading nationwide trials called the PREDICT trial, as well as the PATIENCE trial, and showing that the percent positivity of mycobacterial cultures has decreased, cut in over half, from about 40% positive cultures to less than 20% after starting ETI therapy. So another infection we're seeing less of. I'm also going to just show some other organ systems, a couple others, one being the pancreas and the endocrine part of the pancreas. As I mentioned, about 25% of people with CF will develop CF-related diabetes, something that we tend to see in adolescents and adults with CF. Christine Chan is one of our endocrinologists at Children's, and she helped to lead, one of the studies, the PROMISE study, the endocrine sub-study, that's showing that people on ETI had decreased fasting glucose levels, so lower fasting glucose, which is good. They had lower hemoglobin A1C levels. This is a sugar form of hemoglobin, and lower is good. There wasn't really a significant change in OGTT results. So, if you look at the different possible outcomes of an OGTT, from being normal to the spectrum of CF-related diabetes, and in between there's impaired glucose tolerance, there wasn't a dramatic change in these profiles, but subtle ones nonetheless. This was a study, out of France that looked at those who already had impaired glucose tolerance or CF-related diabetes, but showed improvements in these people with similarly decreased glucose levels, decreased A1C, and there was actually some improvement and some recategorization of people through the OGTT. So again, what I sort of classify as modest impact on blood sugars and diabetes. Another thing that many of you know is we also look for liver disease in people with cystic fibrosis. It's really this sort of second leading cause of badness among people with CF behind their lungs. And so, it's something that besides doing blood tests, we're now doing regular abdominal imaging with abdominal ultrasound and sometimes fiber scans. But this was really very encouraging data that showed really a pretty significant decrease in the rate of progression to severe CF-related liver disease in people on ETI therapy, that these were the people who were developing liver disease prior to ETI, and that the people on ETI, much less risk of progressing to CF-related liver disease, including cirrhosis, varices, liver failure, need for transplantation. So really encouraging data in that regard. And all right, I must have taken out one other slide. This is a slide, just mentioning that Jordana Hoppe helped to lead sort of one of the phase 3 clinical trials of the newest triple combination, vanzacaftor, tezacaftor, and deutivicaftor, which is Alyftrek, in children 6 to 11 years of age. And one of the things that we found in this study was a further improvement or further normalization of sweat chloride in these children. So 84% of children who are already on ETI or Trikafta therapy had a sweat chloride less than 60. That increased to 95% who then rolled over to the Vanza triple, and that 39% who achieved sweat chlorides less than 30, that increased to over 50% of the participants who are switched to the Vanza triple. So again, this is something that where sweat chloride represents CFTR function in the sweat gland, and we think that further reductions, can, lead to further improvements in that CFTR protein, not only in the sweat gland, but elsewhere in the body. I'm now going to turn it over. Emily, I think you can just simply unmute yourself and I can advance the slides, but you're going to just talk about sort of what we're seeing with ETI and mental health and other aspects, correct?
Yeah, thanks, Scott. I'm excited to share one of our behavioral research studies that looked at really behavioral factors associated with adherence to ETI or Trikafta. Scott mentioned a lot of improvements that have been shown in some of the clinical trials related to Trikafta, and we really wanted to look at what are some of the more modifiable factors or behavioral factors that we know may be associated with Trikafta. So next slide, Scott. Okay, perfect. So this was a multi-site survey study. And as I mentioned, the goal really was to understand adherence to Trikafta. So how hard or easy is it for folks to be able to take Trikafta? What are some of the barriers that get in the way of taking Trikafta? And this, one of the unique things about this study was that it was a multi-center study. So we had 18 CF centers across the US that spanned both pediatric sites and adult sites. So we had people with CF in this study who were 7 years of age all the way up to our oldest participant was 74 years of age, which I think is a really unique way to understand what Trikafta looks like for folks at different developmental stages. And really, the things that we were looking at, in addition to adherence to Trikafta, which really just means how easy or hard is it for folks to take Trikafta as it's prescribed, we also wanted to understand relationships between taking Trikafta and some of these other factors that I have listed here. So, is there an association between what people think about Trikafta and how hard or easy it is for them to take Trikafta? Is there a relationship between mental and behavioral health and people's adherence to Trikafta, or how frequently or easy or hard it is for them to take the medication? Is there a relationship between their own perception of their health, both their physical health and their mental health, and their adherence to Trikafta? What's the relationship between body image and Trikafta? Scott showed earlier in some of our registry data that weight and has increased in terms of the percentile in our population being above the 50th percentile. And so we really wanted to look at what does that mean in terms of body image and how folks feel about their body and how that might affect their taking of Trikafta. And then the relationship with the CF care team, does that have an impact on adherence to Trikafta? So next slide. This is a very busy slide and really just a sneak peek. We actually are in the process of publishing several different manuscripts that have some of this data in it, but I wanted to just pull out some of the bigger themes or kind of buckets of data that we looked at. The first thing I wanted to mention is when we talk about adherence to Trikafta, or how easy or hard it is for folks to take Trikafta, this is something that's really not easy to measure. There are a lot of challenges to measuring how people take Trikafta. And so we in this study used two different ways of measuring adherence. So we used what we call pharmacy refill data. So all of the participants who were in the study, we were able to get records from their pharmacy to look at how often they were refilling their Trikafta prescriptions. And then we also used a self-report, which was done in a 28-day daily diary where we texted people every day asking them, did you take your Trikafta today? Did you take it as prescribed, or did you modify the dose in any way? And I should mention, as I said, we had a range of ages of people in the study from 7 to 74. And so folks who are children who are 7 to 12 years old, caregivers, their parents and caregivers completed a lot of these measures. But what we saw was that there was really a high adherence rate to Trikafta. So when we look at pharmacy refill data, there was a 79% adherence rate to Trikafta. And then when we looked at self-report, so what people were saying they were doing in terms of every day taking their Trikafta via that daily diary, that was much higher. People were reporting taking that as prescribed 94% of the time. And that's something that we know exists, that there's a little bit of a higher rate of adherence when we ask people what they're doing every day compared to some of the challenges with looking at refilling medication. And also, not surprisingly, the lowest adherence rate was among our people with CF who were sort of young adults, late adolescents, young adults. So those that were 18 to 35 had the lowest rate of adherence. So when we look at nutritional and weight support, as Scott mentioned, there is an increase in weight that is happening for a lot of folks on Trikafta. We saw that for the first time, there were more people in our study who were considered overweight or obese than those who were underweight. which is something that I think is a shift from what we used to know about people before some of these highly effective modulators. 66% of people in the study reported body dissatisfaction. So this is something we have a lot more data that we'll be publishing soon, looking at the impact of body dissatisfaction, not only on taking Trikafta, but just the impact that that can have. And one of the things that we know is that there are a lot we can do preventatively and interventions we can do to try to address improving body dissatisfaction or body image. Sleep was something else we looked at a lot. And this is, I think, a really interesting and important finding. We found that 58% of people in our study reported poor sleep quality that worsened with age, which is not surprising. As we all get older, our sleep quality declines. But I think when you think about sort of the range of age of people in this study, it aligns with what we know about sleep, that it gets worse as we get older. But we also saw that 16% of people reported that their sleep problems were worse after starting Trikafta than before. So that's something that we really want to think about and look at and really start to more preventatively ask and screen for how folks, including children and adolescents, are sleeping. And if we notice changes, there are a lot of really effective strategies and interventions that we can recommend to help improve sleep. So moving on to mental health and cognition, when I say cognitive symptoms, these are things like brain fog, trouble remembering, noticing difficulty maybe with attention or being able to concentrate. These are some symptoms or side effects that folks have reported after starting Trikafta. One of the, I think, really exciting things we found in this study was that there was a notable improvement in terms of the prevalence of depression and anxiety in our study compared to what had been published previously. We found that about 15% of our participants met criteria for depression and about 13% for anxiety. Previously, what had been published is around 30% in the CF population. So we think that Trikafta may be helping as there are improvements in lung function, weight gain, nutritional status, some of the things that Scott mentioned. The burden of the illness is less, and so that just automatically improves folks' mental health. But one of the things we also found that we really want to pay a lot of attention to is that our kids who were 7 to 12 years old actually screened positive for depression at higher rates than our adolescents and adults. So these were a lot closer to what we've seen in past research. About around 30% of kids were elevated for depression and anxiety. I think part of this is that we have, over the last many years, those of you who have teenagers who come to clinic will know that we've focused really hard on screening for depression and anxiety, meeting with psychologists in clinic to try to make sure that we're supporting you around your child's mental health. And that's hopefully addressed some of the increased stress of CF and allowed for these improvements. And we're going to start focusing on our younger kids and hopefully help proactively address some of these increased risk for depression and anxiety. And then again, depending on the symptom, we found about 13 to 20% of people reported being more bothered by mental health or cognitive symptoms in the past month at the time of participating than before Trikafta. So these are things that, again, if you think about the opposite side, that's about 80% of people who did not report feeling more bothered by any of these symptoms and in fact may have reported improvements. But this 13 to 20% of folks, we really want to understand better. What can we do to help address some of the challenges they may be experiencing with mental health or cognitive symptoms? And then finally, we found that lower adherence to Trikafta is associated with a number of things. So there's a relationship between higher anxiety and lower adherence to Trikafta, worse self-reported cognitive function. So folks that reported having more challenges with memory or concentration had lower adherence to Trikafta. Lower perceived importance of Trikafta. So folks who maybe weren't sure if Trikafta was helping or didn't feel if it was as important took the medication less. Lower medication self-efficacy. So that is just this belief or this idea, this confidence that you're able to take all of the medications that you're prescribed. So people who had lower beliefs about their ability to take Trikafta took it less often, not surprisingly. Lower motivation to take Trikafta was associated with lower adherence. And then more concerns about taking Trikafta. So the takeaway, the sort of take home point in all of this is there's a lot of things that we can modify and intervene on to help feel better if any of these concerns arise. So if any of you notice changes in sleep or emotional health or cognitive symptoms in your children, please let us know so that we can talk about those, give you some support and recommendations. We know that there are a lot of strategies that can help address these things.
Emily, thank you so much. Thank you. And we can certainly, come back to this at the end with question and answer, just with a few more minutes, and then I'm going to turn it over to a couple other colleagues at Children's. But the data we've highlighted is really a lot of the changes on the different organ systems related to modulator therapy, specifically ETI therapy. But right now, somewhere between 6 to 8% of the USCF population does not benefit from a CFTR modulator. And the CFTR modulator, it's a form of protein rescue therapy. It makes the CFTR protein work better. We've talked about it before in this forum. We're going to talk about it again, that there's a lot of work going into alternative strategies, particularly for that 6 to 8% who doesn't benefit from a modulator. So there's approaches to still try to restore the CFTR protein. So people who have X mutations like the G542X or the W1282X, there's different nonsense specific treatments that are being investigated. For anybody, it doesn't matter what their mutation is, mRNA therapy, which is the technology behind the COVID vaccines. The idea is you're giving a normal sequence of RNA that gets delivered into the cell, but not into the nucleus. And that normal strand of RNA then gets translated into a normal CFTR protein. So these are in clinical trials right now, and then antisense oligonucleotides to also restore CFTR protein. And then there's strategies to either fix or replace the CFTR gene, what we used to call gene replacement therapy. It's now being referred to as gene transfer or gene editing, where you fix the few abnormal base pairs inside that CFTR gene that are in a way mutated. And I'm going to show another slide in terms of the clinical trials momentarily, but challenges for all of these have to do with how you get them into the cell. So a lot of these therapies right now are being investigated from an inhalation perspective. So they're gonna fix the lung disease, but they're not going to fix the pancreatic disease or the liver disease or the digestive disease. And getting them into the right cells into the airways is a very critical part of what's being investigated in these clinical trials, targeting these correct cells, and then sort of the safety and the durability. How long does it last? If you get a benefit with one of these therapies, how long does that last? How often will you need to redose? So these are things that are all being investigated in clinical trials. And really just to highlight, what we refer to as these genetic-based or nucleic acid-based therapies, there are several that we are going to learn early clinical trial results next year. So 3 different forms of mRNA therapy. We're going to learn about antisense oligonucleotide. These are for people with these, what we call sort of non-canonical splice mutations. There's a few different ones, but so again, it's a particular type of mutation that this is targeting. And then we're going to get initial results from one of the gene therapy trials next year as well. So again, a lot of activity going on. And next year is going to be a big year in terms of learning about sort of the early results. Just wanted to really sort of finish up with a few different TDN studies that we are approaching you guys, recruiting you guys to do. One is Stop Peds, where the primary goal of this study is really to sort of assess what we're doing to manage outpatient pulmonary exacerbations or respiratory illnesses. Do we need to prescribe antibiotics like we used to? Or could we have more tailored, individualized therapy, starting with more intensive mucus clearance treatments and have reasons to add antibiotics several days into the illness? It's one of the studies. REACH-CF is an observational study. It's collecting key clinical data from a group of people with CF that currently do not qualify for or do not tolerate CFTR modulator therapy. And the idea here is that this group could actually serve as a control group for the various, what I just showed you, the various different nucleic acid-based therapies. Rather than enrolling a control group into each of these, the REACH could be its own control for each of these studies. And so we're right now collecting sort of biospecimens and clinical data from people. And it's not the young infants right now, it's right now older children who are qualifying for this study. Another one is Begin that we've been doing at our site now for a year or two. But one of the sub-studies is a bronchoalveolar lavage sub-study where we're collecting lower airway mucus via bronchoscopy. And this is to sort of more carefully investigate infection and inflammation in the lower airways of these young children. Rarely does a child under 6 years of age cough up a mucus sample. So for us to understand infection and inflammation in the lower airways, we have to do this bronchoscopy. And so we're doing that as a sub-study. And then the Bionic CF study is evaluating the safety and effectiveness of an insulin-only bionic pancreas system compared to your own insulin delivery method. It's oftentimes a pump, or sometimes somebody's just simply self-injecting with insulin. And this bionic pancreas is being studied in people 14 years of age and older who have CF-related diabetes. So with that, I'm going to, I sort of hid my camera. I'm going to come back online and just see. I do see Kevin on and Ellen on. Super. So I'm going to turn it over, guys, to Kevin Wilson and Ellen Stern, who are from our Children's Health and Advocacy Division. Kevin and Ellen, thanks for joining, guys.
Hey, thank you so much for having us. It's great to be along. Thanks so much for the really warm introduction and the warm invitation, Dr. Sagal. Great
It
to
could have been warmer.
it,
I didn't
it,
do it as warm as I could.
it was very warm
Okay.
when we come in and talk about policy and politics. The level of warmth kind of varies based on how everybody's feeling. So it's
And I'll
it's
be happy to
wonderful.
advance the slides for you,
Oh,
Kevin.
perfect. Thank you. Thank you so much. So there have been tons of questions about the federal legislation that passed this last summer and some of the impacts on Medicaid from everything that's going on in Washington, D.C. So we're going to chat about all of that in the next little bit here. Brief presentation, kind of overviewing this, and then want to leave lots of time for questions and answers. But before we dive in, I'm Kevin J.D. Wilson. I work on our Medicaid initiatives and access to care team. And then I'm also really fortunate to get to work with my friend and colleague, Ellen. Ellen, do you want to say hello?
Yeah, hi everybody. So nice to be with you. I'm Ellen Stern, the Director of Government Affairs for Children's Colorado. And I think we can actually go to the next slide, Dr. Sagal. We're just going to start with maybe a little bit of level setting about what myself and Kevin do on a daily basis. So, um, if you don't know, advocacy is actually in the mission of Children's Hospital Colorado, which means, advocacy within the walls of our hospital is really critical, but we also try to advocate and speak up for kids beyond the walls of the hospital, out in communities and down at the state capitol and back in Washington, D.C., on a whole host of issues like health insurance access, healthy eating and active living, injury prevention, mental health. That's really our kind of core strike zone. So tonight we're going to talk about Medicaid, as Kevin indicated, and really some of the big policy changes that have been coming down from Washington, D.C. But I also will give a plug for thinking about how we can work together moving forward potentially. So Kevin, you want to go to the next slide?
Yeah, sounds great. As we start to get into talking about some of these federal changes that are coming, we thought it'd be a good idea to just very briefly level set why it's so important for us to be defenders of Medicaid. Uh, Many or all of you may already know this, but Medicaid is really important to kids. About half of the kids we see at Children's Hospital Colorado have Medicaid coverage. Um, that's considerably higher for kids with disabilities. It's a much higher percentage. If you look at Medicaid across the country, it's about 4 in 10 people who are covered by Medicaid are kids. And then in Colorado, about 1 in 4 Coloradans is covered by Medicaid. So it's a really important program. And any impacts to the Medicaid system, often do have impacts on kids and young adults. So with that very high level kind of in place, let's move on to the next slide. And Ellen and I will spend just a couple minutes here talking about some of the impacts to Medicaid from this the president's big budget bill. It's also known as HR 1. We usually use the shorthand of HR 1 that Congress passed this last summer. Before I get into the details that you've got here on the screen, I kind of just want to be upfront and direct about it. This is not what we wanted to have happen. We just frankly did not want to see this bill pass into law in the way that it was written. Our CEO, Jenna, my friend and colleague Ellen, and her whole team went to Washington, D.C. A number of times through the course of the spring and the summer, meeting with members of Congress and really just talking about our concerns and really trying to urge some caution when it comes to kids' health coverage and the Medicaid program. About 3,000 members of the Children's Hospital Colorado team and a few hundred patient families too also sent some messages in through our Child Health Champions system to their members of Congress, asking for changes or saying, give a little bit more time on this bill. We'll talk more about that process later when we talk about some different ways you can get involved. But really, I think the upshot here is we didn't want to have to be in this position, but now we're all thinking about, okay, this bill is passed. There are going to be some impacts to Medicaid. How can we understand it the best that we can, and how can we engage in some advocacy together to try and prevent some of the worst impacts that we'll see. Okay, so let's look at some of the specifics on this piece of legislation. If you look through these different boxes here, you'll see the different components of the bill. These aren't all of them. These are just a few of the really substantial changes. And you'll notice that there are different active dates, different times when each of these pieces of the bill will come online. And, I think as you're thinking about this, one of the things to know about the bill is not everything is going live immediately. There is time to engage in advocacy and change bits and pieces of it. But high level and kind of structurally, the big thing to know about the bill is, at the core of it, it has a lot to do with tax cuts. It was important to generate a lot of savings in order to pay for those tax cuts. And the place where most of those savings have come from is from the Medicaid system. And so a lot of what the bill does is it does things that will decrease the amount of money that the federal government spends on the Medicaid program. But that, as we'll get into in future slides, basically will pull money out of our state's ability to pay for Medicaid. Again, maybe just to reiterate the high level, and then I'll pause and see if anybody wants to talk about any of these specific things here, because some of them are pretty technical, but always happy to dish on details. Again, when I'm talking with folks here at the hospital or with my own family, the point I try to reiterate is a lot of this is phased in over time. We don't want to be unrealistic. It's going to be a lot of challenges for Colorado's Medicaid program in navigating all of the big, particularly financial changes that come along with the bill, but it doesn't all happen at once. So we got a little bit of time. Ellen, what else would you add on the specifics here? And then I'd love to know what questions folks have before we get into a little more.
Well, maybe just top line, the federal bill will cut Medicaid by about $1 trillion over the next 10 years. That amounts to about a 14% cut to the Colorado Medicaid program. And as we'll share in future slides, there's a bunch of changes right now, and this details administrative changes to how families enroll in Medicaid, changes around how you may have to notify the state on a monthly basis around work expectations. So those are all going to be phased in over time. But the expectation is that people may lose Medicaid coverage. There will be less federal funding for Medicaid. And as a result, the state has less ability and flexibility to really invest in Medicaid. So we absolutely can go into more of these details, but I think maybe the more important pieces are around how the state is responding. But why don't we pause and see if there's any questions or if people want to talk through any of these?
And maybe just to give a little bit, very quick commentary while folks have a chance to think about any questions they might want to ask. A lot of these that you see on your screen aren't explicitly focused on kids, right? So there's work requirements for adults. There's these more frequent eligibility checks for adults. A lot of the way that Congress debated it really had very little to do with kids. But a thing to keep in mind is it costs the state an awful lot of money to administer all these new requirements, to build out all these new systems. And so they have to cut somewhere to come up with the money to pay for things that the federal government is now requiring them to do, even if it wasn't, intended necessarily to impact kids. Okay, any questions on these specifics? If not, we can keep rolling on through to talk about the state and what some of the impacts here are going to be.
I just speaking selfishly, not so much as somebody who's insured by Medicaid, but children's. When we think about our CF care team, many members of our care team are children's employees paid for by the hospital who don't bill for their services. We have respiratory therapists, we have dietitians, we have social workers on our team that play a critical role in helping our families, and they're paid for by children's. They don't bill for their services, and any significant decrease of funding to our hospital can affect care team members and the care we provide to our families.
That's a great call out. And one of the unfortunate things is, Medicaid already is not a terribly well-funded system. And so, I personally just working with Medicaid every day, I have a lot of concern that even if you're pulling out, in percentage terms, 10 or 15% of the funds for the program, there's not a lot of fat. It's a pretty lean sort of system already. Let's go ahead to the next slide, and if folks have questions, just chime in or feel free to drop them in chat. So we kind of previewed this, but one of the things that's tough here is the passage of this bill, because it shifts a lot of the funding away from the federal contribution to running the program. It ends up creating a gap here that will be a substantial budget hole for Colorado. So Medicaid programs are jointly funded by the federal government and states. You can see here in Colorado, about 35% of our Medicaid budget comes from our own Colorado tax dollars. And then the rest of it, about 65%, comes from federal revenue. And then if you look along the bottom, all these different years here running from 2026 through 2031, the pie charts basically show how things are going to change, where the federal share decreases over time. The state continues to pay our portion the way we have, but then you end up with this blue slice that gets bigger year over year, which is essentially a gap, saying, there's just not enough money for the state of Colorado to keep running the same Medicaid program that we've had. Again, because Medicaid is already pretty underfunded, that's one of the reasons that we're worried about, kids' benefits and coverage and a bunch of other stuff like that. Again, I'm not meaning to be optimistic here. You'll notice these cuts start small. For the next couple of years, things are potentially going to be manageable, but it really does start to open up and get to be much more difficult once you get into 2028, 29, 30, and so on and so forth. I think in a second, I'm going to turn it to you, Ellen, and maybe you can talk a little bit more on the next slide about timeline.
Yeah, absolutely. I think we're looking at the next 18 months as being really important planning work for the state to effectuate some of these changes um, on the administrative side, right? That Kevin spoke to, technology changes, eligibility changes. What I think we're most worried about, though, is immediate cuts to Medicaid as a result of st changes to the financing. So, state lawmakers were called back to a state special session in August. They typically only meet from January until May in Colorado, but they were called back after Congress passed this bill in part because Colorado's tax code is quite aligned with the federal tax code. And because of all of these tax policy changes, it led to about an $800 million deficit in a balanced budget that we have to have every year as a state. And so the governor had some ideas about how to take immediate action, including using some of our kind of state savings accounts from our rainy day fund to stop that $800 million deficit. Also using some immediate cuts to Medicaid around access to prior authorizations for behavioral health and some changes to waiver financing. So there were some immediate impacts that we're already seeing this year as a result of that reduced money coming into the state of Colorado due to kind of bigger and broader tax policy changes. What we're really concerned about is the upcoming state regular session, excuse me, that starts in January. The governor's just released his proposed budget, and maybe we can go to the next slide, which kind of articulates what the state options are because of this revenue gap as a result of the federal law. This could be the state could raise revenue, right? There's less revenue now coming into the state to pay for things like Medicaid and other child health priorities, but that requires a vote of the people. There are discussions happening out in the community about options in that space, but that's a big effort to get voters to approve changes around any new taxes or changes to taxes. The one we're really focused on are these three elements around potential cuts to Medicaid through provider rate cuts. That would mean providers who see Medicaid patients would be paid less. And that's where the governor right now is focusing a lot of his effort, which is about a $500 million impact over the next couple years, not this fiscal year's, Kevin, next fiscal year. That would mean potential access issues if primary care providers are no longer able to take as many Medicaid patients because they simply can't make the finances work. That may lead to more emergency room use or other downstream impacts on child health. So we're really concerned about what those payment reductions will mean, particularly for very small practices who are already on shoestring budgets. And as Dr. Sagal said, these will have impacts on hospitals too. There's targeted rate cuts to providers in pulmonology that Medicaid is proposing, sleep studies, maternity care, things like that, where there will be a direct impact on the caregivers who treat patients. So far, the governor has not wanted to change anything about Medicaid eligibility. We'll see if that holds out with the legislature, which now has to consider and approve a budget, makes any big changes around eligibility, but at this point, that's not been a target area. So I guess we should be really clear in emphasizing there should be no changes to anybody's Medicaid access as of right now because of these policy changes. That could change in the future. And as these new administrative policies roll out, that may impact access for many patients. But as of now, there's no direct eligibility changes. And then we're watching, obviously, benefit changes. And maybe we can talk, Kevin, a little bit about things like specialty drugs and other
Yeah.
ways that HCPF, the Colorado Medicaid Agency, is thinking about kind of ramping down some of their costs.
Yeah, one of the things that we're concerned about is the state's continued focus on what they call specialty drugs. They're very right that there is a real affordability and cost issue at play here with a lot of new, groundbreaking, life-changing, life-saving drugs and medicines, therapies that have come onto the market, have been FDA approved in the last 5 years or so. Um, And now something like 2% or 3% of Colorado Medicaid spending on drugs, or let me phrase it a different way. 2 or 3% of the drugs that Colorado Medicaid dispenses or pays for are consuming like half of their pharmaceutical budget. And so, we do have a fair amount of concern that Medicaid's going to look at what are the ways in which they can, crank down on spending here. So as we're gearing up for our defense uh, of child health access in the upcoming year, this is, one that I think we, as always, have to take a pretty nuanced view of. But we really want to try and preserve access in any way that we can, and give folks, plenty of ample opportunity if there's anything that the state is contemplating that we feel like could hurt, patients, families, or access to care. I know we're nearly out of time, so we might
Should
keep
end on a
rolling.
bright spot, though.
Yeah, let's do it.
Maybe just a word on this slide, and then we can talk about advocacy opportunities to partner with Kevin and I. Every time Congress passes a law or the state legislature passes a law, there is always an opportunity to come back and educate them about the impact of that policy change. New information comes to light. New members are elected to the comments in the chat. So there's always an opportunity to kind of write again a new chapter in the advocacy journey that we're all on always. And I think that's really the case here with HR 1. Right away, there's been continued advocacy. The day after the bill passed, there's people continuing to knock on the door of members of Congress to talk about this bill, and that will continue to be the case. So hopefully we'll see some continued reconsideration and information that helps Congress potentially look at this differently in future years. And we will continue to be strong advocates because we believe so strongly in children's rights to access the Medicaid program and have accessible care options. Let's move to a kind of what can we do next, just since we're right at time. Kevin, do you want to segue into this?
Yeah, I'd be very happy to. So, maybe just to tee it up for Ellen, who's my smarter friend and colleague here. We're going to continue fighting here, but we really think that, everybody has an opportunity to be a messenger. We can share more on one of our next slides on at least one kind of specific, easy to do thing that you can get involved in. But I guess I always encourage folks, keep track of the news on this sort of stuff. Have conversations with friends, family, people you work with, about the importance of protecting kids' health and access to care. Don't be anxious about calling up your member of Congress or a member of the U.S. Senate. I spent a little time working in an office in D.C. My friend Ellen worked for a U.S. senator. They take calls. They keep track of what they're hearing. It really does have an impact. And the same is true here in Colorado, even more so. Talking with your state legislators is just very important in terms of communicating the importance of programs like Medicaid, the importance of having affordable health insurance, to being able to stay connected with care, to being able to afford medication, and so on and so forth. So, I think my kind of high level on this is every opportunity you get, maybe don't be a complete pest like those of us who work in government affairs, but every chance you get to talk about this stuff with people who care, I think it's really important. What else would you add on that, Ellen? And then
Well, just maybe, a shout out to the CF community. We have worked together over the years on newborn screening legislation. Dr. Sagel's been a huge champion in making sure the law works for families to be identified early and get connected to care, and that the systems work for kids and families. So, strong advocacy at the state level on those types of issues. And then we were really fortunate and honored to take a family with CF to DC last year to really speak about Medicaid and prescription drug access and the importance of teaching hospitals and just a beautiful story that we could share with all of our members of Congress. And so we're just so grateful for any opportunity to work with families to help be a facilitator in making the advocacy connections. And so we welcome the opportunity to work with you on Medicaid advocacy or any other topic. If we can be a partner in your advocacy interests, we'd be really delighted to do that. I think we'll pause there and see if you have any other questions. This is our network that we have. Sorry, Kevin. We operate a Child Health Champion Network, and we provide timely updates, a monthly newsletter, and then when we're working specifically on topics, we try to kind of rally the troops for communicating on major child health issues. And we'd love for you to become a part of it if you're not already.
We've overspent our time, but we want to see any questions, comments, discussion from folks on the call.
Yeah, Kevin and Ellen, thank you so much. In terms of, I'm stopping sharing because if there's any questions, and the other thing is, Kevin and Ellen helped us greatly just a couple years ago when Colorado established this Prescription Drug Affordability Board, and they started to review expensive medicines to maybe negotiate reduced prices or not to pay. One of the first of the 5 drugs was Trikafta, and there was, there's significant concern in our CF community that Vertex was not going to negotiate with Colorado's Prescription Drug Affordability Board, and that our patients were going to lose access to Trikafta. They helped to advocate for us in this regard. So again, there's lots of these areas that we really do count on our advocacy and policy experts like Kevin and Ellen. So thank you, guys.
We're going to reflect that right back on you and the whole team. You were just such an incredible champion and participated in a lot of tough conversations with state policymakers and board members and sent off a whole bunch of different letters. So I think every little bit on this helps, and really highlighting your own stories, your own experience. I think it just makes all the difference in the world when it comes to policy. So just encourage everybody to participate.
Right. Again, if nobody has questions or a little embarrassed, I just will say it's helpful also, Kevin and Ellen, for us to hear this too. While we know some of the little bits and pieces of changes that are coming, I've learned from you guys tonight. I'm not going to sleep quite as well. But
thanks for the invitation. I'm going to put my email and Kevin's email in the chat. Please reach out for any questions on Medicaid or any other topic. I'd love to hear from you, and hope you all have a good rest of your meeting.
Great. Thanks, guys, for joining.
Thanks again for the invitation.
Thank you. I'm going to turn it over to Mike Turner from the foundation with a few Rocky Mountain chapter updates.
Perfect. Awesome. That was great. So I'm actually going to start with piggybacking on what Ellen and Kevin just talked about, which is advocacy, and just make a plug real quick for, let me share my screen real quick. For more advocacy, because they are 100% correct in that it is extremely important. The CF Foundation Advocacy Department actually put together a advocacy alert system where you can respond directly to CF issues, to contact mostly our federal legislators. So I'll put the link to here, but the easiest thing to do is to just text Fight CF to 96387. And again, I'll put that in the chat, but plenty of ways to get involved with advocacy. I also dropped the link to the Children's Hospital advocacy page because it looks like they have a similar alerts where you can advocate for more than just people with CF. So highly recommend you do that. Super easy. I'm sure their system is similar to ours in that it gives you the script. It plug and play. You just type in your zip code and it tells you where you're going to send it. You hit send and you attach your name and you're done. Very easy to get involved. So a couple of the things I wanted to highlight tonight. One is Compass. Medicaid, as we just heard, is a huge issue. If anybody needs help with insurance, or anything dealing with Medicaid or anything, CFF Compass is an amazing resource. If you haven't called them before, if you need help, it's a completely free resource that the foundation supports. You get assigned a case manager, and they can help work through any issues you have in employment, job changes, or anything like that. So again, I'm going to put all the links in here. You don't need to copy anything down right now. But just want to do a plug for Compass because it's going to be very important, as you saw, as we get toward not just for Medicaid, people with Medicaid, but I know rising health premiums are coming and a lot of other not fun stuff that we're all going to be dealing with. So please utilize Compass. The next thing is CF Peer Connect. CF Peer Connect is a program where parents and people with CF and caregivers can connect with someone else in their similar situation to serve as sort of a mentee-mentor relationship. So if anyone here is either looking to be a mentor, maybe you've been around for a while and seen a lot, and you want to help people out and maybe connect with newer families or people who are in changing situations. This is a great opportunity to become a mentor. It's also a great place to get support and become connected. So I know we've had a lot of families utilize it. We've had a lot of parents utilize it. We've had a lot of spouses of people with CF utilize it as well. So it is, again, free program through the foundation. Similar, something new this year, it's called CF Circles. They're a kind of small group, very specific small group discussions that they host about once a month. There's a different topic. Right now, most of them are focused for adults with CF, but they are going to be expanding this program in 2026 to include a lot of parent topics. And so you can kind of see down here, the next one is living with GI issues. So for adults with CF and parents and caregivers of people with CF managing GI symptoms. So if that is something you're interested in learning more about or connecting with a group about, CF Circles is a great way to do that. It's an online program. So you just sign up. You get the Zoom link similar to this. You join the meeting, and it's an opportunity to connect with other people going through the same issues on those topics. And you can see here's a couple other topics that they've had, and then they will be expanding those in the coming months. And then the last thing, where did that go? Is locally. So locally, our Rocky Mountain chapter, we have finally finished up all our events for the year. We had our gala on November 1st, had a wonderful experience, raised a lot of money, and had a wonderful evening honoring the Boylan family, whose daughter Sarah is 36 years old. And they've been involved for 36 of those years with the CF Foundation. And I know with Children's, many of you have walked down the halls of Children's Hospital and seen Sarah's pictures that she did, her artwork that she made when she was a pediatric patient many years ago. So gala was fantastic, but we are already started on 2026. And so we already have our events for our first group of events, our Great Strides season for 2026 posted. Dates are here. Again, I'll share these out and send these and put these in here in the chat. So just thanks again for everybody. I did want to allow Amelia Worthy, if you are still on, I would love for you to come off mute and talk for a second or a little bit about the Breathing Together group that you all have convened. Amelia, are you still on?
I don't see Amelia's name.
Oh, no, she may have had to jump off.
She may have.
Well, I will do it real quick.
Please.
So, long time ago, we had a program called CF Cares, and Amelia wanted to make it much more of a combined effort between the Care Center and the Foundation. And so Amelia got together with the group, the Family Advisory Council, and decided to rebrand it and create a new thing called Breathing Together. So it's a monthly parent meetup that we're currently hosting I'll have to get the date exactly. It's next week. I'm not sure the date and time, but I'll look on Molly's calendar here in a minute. So we have our December Breathing Together at Junction Food Hall, which is at Colorado and I-25, right next to the Dave and Buster's. It's free, open. Oh, it's the 11th, 6:30 to 8:30. Thank you, Diana. At Junction Food Hall. So again, free event. We buy a dinner, we buy a drink, your first one. An opportunity for parents of all ages. You know, you don't need to have little kids or older kids. Anybody who just wants to get together and connect, and just talk. You know, there's no pitching, there's no fundraising involved. It truly is just an opportunity for parents to get together, meet each other, you know, get a night out, and connect. So Breathing Together next week, the 11th, 6:30 to 8:30. And if you have any interest, please shoot us an email, and then I will send out the form to register for that with the notes as well. So awesome. Thanks. That's all I had.
Thank you, Mike. That's super. Again, the foundation is such an important resource to our families, to us as a program. So it's awesome, all the things that are available, especially Compass. It's going to be so important for our families. That's the end of our presentations. It looks like, some of you had messages in the chat that team members answered, but certainly happy to entertain any other questions you guys might have.
I think there may be some other questions.
I didn't look carefully.
I think Jordana answered the question about a lift track, but I think the basic answer is we don't really know yet how it compares with Trikafta as far as mental health side effects. We haven't seen anything that suggests that there's issues, but I think we're looking at that. And as Jordana said, there is a study that we're enrolling right now for people that had difficulty with Trikafta who now are taking a lift track. And the liver effect of a lift track seems to be about the same as Trikafta. But I think one of the interesting things to remember about the liver is that while we do have to monitor the liver really carefully because you can have liver function elevation, like what Scott showed earlier, is that overall, we actually think there may be benefits to the liver of these medications. So that's a really important thing to keep in mind too. Let's see. Others see other questions.
There was one, related to federal funding, that there were, absolutely affects research. I mean, you guys may or may not know, but the CF Foundation was very strategic about where they located their national offices. They located their national offices in Bethesda, Maryland, right next to the NIH, because they felt that getting closest to a cure was to be, by the science. And the NIH, for years was our crown jewel, but there have been cuts to the NIH. There have been cuts to grants. Many of us do research that are funded by the NIH, and there have been cuts to those, and that's going to affect things in some ways. So, fortunately, again, we have the CF Foundation that has been able to fund a lot of research efforts in CF, but it's not a good thing that there's cuts at the NIH, that there's cuts at the CDC, that there's cuts at the FDA. That's not a good thing for a rare disease community like CF.
Yeah, I think the other thing I'll just point out about that is that, when you look back at modulators really started in development around the late 90s, early 2000s, and a lot of it was in academic labs. So these were things that were funded by NIH. Maybe they didn't seem like they were going to have that much promise. There were a lot of things that maybe didn't work, but then some things did. And you sort of built on that knowledge. And then eventually, as you build on that knowledge, then it can move out to industry and to other things that can help fund it. But really, our genetic therapies, in a lot of ways, are sort of back at that starting place where those modulators were 20 years ago. And so that academic work to really try to figure out all those things that Scott described as being really hard, like getting delivery and, getting in the right place and making sure it's safe. And all of those things are really happening in a lot of ways in the academic world. And so those are very, very much impacted. So I think making sure that, again, people hear from us about how important NIH funding is for to get that basic science so we understand and can build on it and get to those really amazing therapies like Trikafta. Yeah, and yes, and someone pointed out the venture philanthropy, and yeah, this has really been kind of an amazing model and has gotten us, where we are today, I think so, in many ways.
Okay. If there are no other questions, we can end. Thank you all for attending. Thanks to our CF Care team who helped put together the slides for tonight's presentation. Thank you, Edith, for keeping an eye on the chat and responding to some of those questions online, and to Jordana. This will be recorded for those who are not in attendance, so we could share with others as well. If you have any other questions, feel free to reach out to us at upcoming clinic visits. We hope you all have a great rest of your night, great holidays. Thanks all.
Thank you all for joining.
Thank you.